Afternoon, and thank you for joining us for today's VIA VitaFlow in Association with You live webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We are excited to bring you this educational activity and introduce our speaker. Today's topic is practical considerations of a plant-based diet in pediatric CKD. Please note, this program is being recorded. You can access the PDFs of the handouts in the handout section in the control panel to your right. If you are tuning in via a phone line, don't worry if you cannot access the slide deck. It will be emailed to you at a later time. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you're welcome to submit text questions into the questions pane at any time during the program. Questions relating to product will not be addressed during this webinar. Feel free to contact your VitaFlow representative for product information following the program. I have the pleasure of introducing our speaker today. Christina Nelms is a registered dietitian with over 15 years of experience in pediatrics, primarily working with renal patients. She's held several clinical positions, most notably at Children's Mercy Hospital and clinics in Kansas City. Christina has been involved with speaking and educating at local, regional, national, and international professional renal meetings. She is also a member of the International Pediatric Renal Nutrition Task Force, whose main goal is formulating clinical practice recommendations to enable best practice in the nutritional management of children with CKD. She has been instrumental in setting up and leading the Pediatric Renal Dietitians of North America, also known as PRONA, which is the first professional practice group aimed at serving as the leading source of pediatric renal nutrition expertise in order to improve patient outcomes, as well as promote community and networking amongst pediatric renal dietitians. At this time, I will hand it over to Christina.
Thanks so much, Michelle, and thank you everybody for attending today. I'll start with my objectives for our discussion today. We're going to kick it off by exploring potential benefits of a plant-based diet, and we're actually going to keep this part brief just because I feel that there's been a lot of discussion. This is a very hot topic in the renal community now. We're going to talk about it a bit for those who are unfamiliar or those who want to review. If you want a really in-depth look at this, Katie Rappolt did an excellent talk on this at the annual dialysis conference last year, and I believe that they have recordings of that. So we are going to explore this, but my goal today is to really look at some practical applications. How do we do this realistically? So we're going to talk about potassium because that is one of the biggest barriers that I hear in relation to can we really implement plant-based diets with our CKD patients, strategies to successfully implement, and then we're going to talk through a case study. So a heads up, this is an interactive case study. So get your thinking caps on because you're going to be asked to type some answers and share your thoughts during this case study. And as a disclaimer, I would like to just say that I am not a vegetarian. I've heard many great speakers on this topic who are vegetarian, but I feel like implementing a plant-based diet is often a trend in heading toward more plant-based foods. And I can say that with both my private practice patients and my family, I am trying to get us moving toward a little less meat and a little more plant-based foods for lots of reasons. And So I live in the Midwest, beef country, and I feel like I relate to a lot of the challenges that some of our families have with being scared of trying more of a plant-based diet, or that term being fearful to them. I mean, my husband's a big carnivore, and I've had failures and successes in my own journey. I'll tell you what, the black bean burgers were a total flop, but everybody loves my black bean soup. So it's definitely a process. And and again, hopefully we're going to talk about ways to implement this gradually and realistically, as opposed to just a whole diet overhaul. Why a plant-based diet? Why are we even pursuing this, for those who may not be as familiar with this concept? Well, this is definitely a big push from the National Kidney Foundation, as we are discovering more and more about the benefits. The NKF describes a plant-based diet as eating mostly whole grains, fruits, vegetables, legumes, unsalted nuts, and healthy oils, while reducing animal foods such as dairy, eggs, fish, meat, and poultry. And in addition to this definition, the NKF goes on further to say that additionally, high processed and refined foods, even if they are plant based, should optimally be limited to optimize health. So, again, like I said, certainly vegan or vegetarian diets fall in this category, but other great diets that I think many of you are probably very familiar with, like the Mediterranean diet and the DASH diet, fall into this category. And again, the goal is just shifting in a direction of more plant-based foods. Um, of note, the National Kidney Foundation is partnering with Meatless Mondays, just kind of the promotion of a short, even one day a week, we can make a difference in the health of our patients. So you'll see a lot of graphics throughout the presentation that come from that source that are free on the NKF website. So, just a quick overview of some potential benefits of a plant-based diet. First of all is fiber. And typically, more plant-based diets are higher in fiber, which can improve fecal transit, which we know may actually help move uremic toxins through the body more quickly, as well as providing prebiotic materials and hopefully making that gut microbiome more favorable. Antioxidants. Typically, plant-based foods have things like vitamin C, vitamin E that can benefit our patients' overall health, prevent chronic diseases. There's a lot of literature on the improvement of hypertension. So, a meta-analysis in typically mostly adult patients with 32 studies shows that vegetarian diets are associated with reduced blood pressure levels. One study that I found really interesting was the Cardia study, because it had a large number of participants, and more importantly, the demographic was 18 to 30-year-olds, which is a little bit closer to our pediatric population. A lot of this stuff, unfortunately, we have to rely on the bigger adult studies and extrapolate it down to peds, but I'll be talking about some ped specific stuff throughout the webinar today. So this Cardia diet showed that with a dose-dependent level of fruit and vegetable intake was associated with reduced levels of blood pressure, and that more meat and processed foods was associated with a greater risk. One thing I always say as a dietitian is I'm less about limitations and more about promoting more. One of my side jobs that I do is teach college students who have abysmal diets. And one thing I'm always encouraging them is just think, what fruit and vegetable can you add to this? Sometimes it's about adding, and sort of inadvertently, when we add more fruits and vegetables and fill up on those, inadvertently, we may eat less meat and processed foods. And certainly reduced acid load, which we're going to talk about a lot more in detail. So, a really nice study, another pretty big study, high end number, specifically of people with chronic kidney disease, a GFR of less than 60, known as REGARD study, looked at food frequency questionnaires and dietary patterns, and found that those with a Southern style diet, foods, fried foods, organ meat, sweetened beverages being very prevalent, was associated with a higher mortality risk. and that a diet high in fruits and vegetables, on the contrary, was protective, not only for mortality risk, but also progression of CKD. They found that those who had high fruit and vegetable intakes had lower amounts of albumin in the urine, and those with higher sodium and saturated fats, also associated with this Southern style diet, were associated with higher levels of albumin in the urine, which is a marker of progressive kidney disease. So let's turn to some pediatrics specifically now. So we know that acidosis impairs growth. There has been a lot of literature. This is a big topic in the world of peds renal lately, the concern about acidosis. And it's one that I've found myself increasingly interested in. What can we do about acidosis? So we know that acidosis impairs growth, which is a big deal for our patients. And we also know, and this is the CKID study that I've highlighted here, that shows that being acidotic, having lower serum bicarbonate levels, is associated with more rapid progression to end stage. Now, the same study showed that unfortunately less than half of children with acidosis were on alkali supplements, things like sodium bicarbonate. So I understand people maybe saying, oh, well, we just put our patients on sodium bicarb to get their CO2 levels up, but not all of our patients are receiving these. And is there a reason for that? Are we considering pill burden? Are they not able to tolerate it? Does it alter the taste of formula, for example? Do we as dietitians have something to offer in terms of alternatives? I know I would rather my patients improve their diet as opposed to giving them another pill. So that's why I think this is a really big deal, and an especially hot topic for our population. We know that plant-based foods tend to have a higher alkali content, and something called potential renal acid load, that we're going to talk more about in a second, is a big predictor for acidosis. And we know that higher PRAL levels are associated with animal proteins. We also know that this is particularly a big problem if you have kidney disease, because the adaptations that the kidney makes to get rid of extra acid in the urine promote kidney injury. So this accelerates kidney disease in our patients, and it's not good for those of us who do not have kidney disease. It's known as subclinical acidosis and is not great for the general population. So this really demonstrates what that potential renal acid load, that I'm going to refer to as PRAL from now on, it is comprised of 5 nutrients. Nutrients that promote base or an alkali are potassium, magnesium, and calcium, whereas phosphorus and protein promote more of that acid. And unfortunately, protein-rich foods make a much bigger impact on this balancing act. Our goal is to really be acid neutral in our urine, but not many of us actually are. Most of us have acidic urine, and particularly animal-based proteins really promote this acid balance. Ciala defines PRAL as the contribution of a food or dietary pattern to net exogenous acid production. We're going to look a little bit more about what foods contribute and how they contribute later on. So to look specifically at a really nice pediatric study that just came out in the last year and a half, a group of Venezuelan children, they assessed acidosis and PRAL and found that 79% had elevated PRAL levels. Now you may say, oh, this was Venezuela, this isn't the US, but I actually think that from what they reported, this is more the influence of westernized diets affecting other cultures, or Americanized diets affecting other cultures, because what they found was that 44% of their patients never consumed any kind of vegetable, and that juices or shakes were the primary source of fruit in their diets. And these children, the ones that did have higher fruit and vegetable intake, had lower PRAL levels. Those with higher energy, protein, and fat levels had higher PRAL levels. And why I think this is as important is the CKID data shows us that that North American kids report really low levels of fruits and vegetables in their food frequency questionnaires that was done in one of the major CKID studies. And that these patients have higher calorie and fat protein intakes from that CKID study, which is associated with PRAL level. And you can just see how dietary acid load not only affects bones, but it affects the kidneys in a couple ways with complement activation and fibrosis, as well as affecting muscle mass, which we know is a big deal for many of our patients, even in pediatrics. So this slide, this is a figure that I took from a DARE, and of course we could have looked at many more foods. This is just a snapshot, not universally, but you'll notice for the most part that the plant-based foods, the fruits and vegetables, are more alkaline, whereas of course fatty foods, meat, dairy, and eggs have very high levels. If you eat some medjool dates, that's a great way to increase your alkaline load, because the majority of foods in a typical American diet are more on that acidic side, and we really want to include more foods to try to change that balance. So just something to think about when we're looking at what we want to encourage our patients to eat. A really great study, Gorea et al., and forgive me if I have mispronounced that name, but a series of studies that she did, this, I've cited the latest one here, looked at adult patients with serum bicarbonate levels. And what I thought was so fascinating is her conclusion was that serum bicarbonate levels were able to be improved so that patients were no longer acidotic, either with supplemental sodium bicarb or with increased fruit and vegetable intake. And in this study, it was really interestingly designed. They gave patients a prescribed amount of fruit and vegetables that were to promote more alkaline urine. And unfortunately, they did not describe exact numbers or average numbers, but it was individually prescribed. Each member of their family received the same fruit and vegetable package, so they wouldn't feel the need to share between lots of family members. And they were welcome to eat more fruits and vegetables if they wanted, but they found that these study participants were able to do it with just fruits and vegetables. So we're going to dig a little more into nutrition benefits of plant-based diets. So we know that we have an increased intake of micronutrients. So certainly if we can get our micronutrients like manganese and zinc, copper, the B vitamins through foods, that's always better than a supplement. Typically, we reduce the intake of processed foods. Again, a plant-based diet isn't mutually exclusive from processed foods, but it tends to include less. Glycemic control, perhaps less of an issue for our pediatric patients, but an issue for some, can be improved. Fiber, again, the data is really with the fiber. The one study showed that with a mean fiber intake, and granted in adults, of 27 grams per day, reduced creatinine and urea levels. Additionally, we know that NHANES 3 data shows us in the general population that higher total insoluble fiber intake is associated with reduced mortality. We know the benefit for improving the microbiome through pre and probiotic materials, hyperfiltration, which is huge for our patients, healthier fat intakes, again, not mutually exclusive with a plant-based diet, but we tend to see more omega-3s in that type of diet. We know that plant-based foods are associated with reduced inflammation in those specifically with kidney disease. And anybody who knows anything about kidney disease knows that inflammation is one of our major enemies in comorbidities of our patients. Again, not necessarily prescribed so, but it tends to be thus that when you have more plant-based foods, more fresh produce, you eat less sodium. And again, we've talked a lot about alkali load. So this is a figure from Adair, and their article really focused on a whole food plant-based diet. Now, I don't think we have to go that far. I think just including more fruits and vegetables, more plant-based foods in general likely achieves this. But you can really see with this visual how um, with excess protein or with reducing protein intake, because we know that most of our patients get more protein than they actually need. We improve things like FGF-23, phosphorus, ammonia, etc. And with higher fiber, we do things like reduce cholesterol, urea, creatinine, improve short chain fatty acid production, and overall we have improved kidney function. This kind of leads me with this next quote I have here into what we're going to talk about next. Um, Typically, our CKD patients are focused on renal diets. And if you could imagine me putting renal in parentheses, that focuses on individual micronutrient restriction. We're focused on things like potassium, phosphorus, and sodium. But is that really the right approach? There's actually no evidence saying that the renal diet, quote unquote, is effective in preventing the comorbidities that accompany CKD. So we're going to talk about that. Before we move on, though, I do want to say, just sort of as a disclaimer, that there are concerns with any diet approach and doing it correctly. Certainly, we need to make sure we have adequate calorie consumption. Now, for some of our overweight patients, reducing calories with a plant-based diet may be considered desirable, but for some of our patients, we have to be careful that we choose high-calorie, nutrient-dense plant-based foods. Nutrients like B12 are important, especially if our patients would pursue a vegan type diet. We need to find a substitute for B12. Calcium, if we're limiting dairy foods, we need to consider that. Zinc and iron, we need to be careful in the foods that we choose to promote enough of those. Accessibility, we can't pretend that all of our patients have automatic access to tons of produce. There are workarounds, but certainly that is an issue, as well as food preparation skills. A lot of our families have never made an eggplant before or know how to cook even frozen fruits and vegetables. Excessive potassium content, which we're going to be talking about quite a bit next, and protein content, which may not be as much of a concern as we think. What about potassium? This is the thing that I hear discussed the most when we talk about plant-based diets and their implementation in CKD. Is potassium really a problem? Intake of potassium really a problem? So what's interesting is the National Kidney Foundation recommends no potassium limitations until serum levels are elevated. And in fact, a high potassium diet, and really that means meeting the adequate intake, because hardly any of us do that, is recommended as a protective factor, because hypertension is treated when we include more potassium in the diet. So according to several experts like Dr. Kalendar Zeta, who is sort of a leader in practice in the adult kidney world, they would say that you should limit potassium only at stage 3 and beyond if you have frequent or severe hyperkalemia. And we know that that can be related to medications like ACE and ARB inhibitors, although it would be argued that if we control the hypertension in the first place with a good diet, we may not be facing that as much. But really, until the GFR reaches about 15 to 20, we are excreting potassium adequately. So that same article would say that stage 4 or 5 in dialysis patients should limit their potassium to 3 grams a day with a high fiber focus. Now, this is all adult based, and we unfortunately don't have any specific guidelines by CKD stage in children, but I think it's safe to say from what we know about physiology that really we don't need to limit potassium until it's a problem with the labs, and even then, we'll talk about that more, whether it's really a problem. So, and of course, PD patients have a greater allowance than hemodialysis patients. What we know from several studies is that potassium intake from the diet is very weakly associated with pre-dialysis serum potassium levels in hemodialysis patients. A study by Nori et al. Of 224 hemodialysis patients found that actual dietary intake only accounted for about 2% of the variance in that pre-dialysis serum potassium levels. And interestingly, this article by Kapisky showed that several studies, this was a systematic review, showed that vegetarian diets are not associated with increased levels of hyperkalemia. Now, this other nice article by St. Jules that really examined all the literature about potassium in the diet says that ultimately this approach, limiting high potassium plant-based foods, is really not evidence-based. We don't actually have any evidence to say that limiting potassium in the diet helps control serum potassium levels, and it may actually present harm to the patients because we're discouraging healthful foods. So what the thought really is do we need to be considering non-dietary causes as our primary source? The National Kidney Foundation and other organizations say, we don't really have evidence to say that eating high potassium foods causes hyperkalemia, but we don't really have enough evidence to say that it's not a problem at all. So for the most part, it is considered prudent to still encourage high fiber, low potassium foods, but maybe not promote the highest potassium fruits and vegetables. But certainly we should be looking at some of these other issues. To go into this a little bit further, we know that the body adapts really well when the kidneys don't work. Yes, our kidneys are usually how we get rid of potassium in excess through our urine, but the body adapts when your kidneys don't work through the stool. And hemodialysis patients actually have potassium excretion through their stool up to 3 times as much as healthy adults. So if you consume a 3,000 milligram potassium diet, up to 80% of that is actually removed from the stool. The body adapts really well. Higher serum potassium levels are often seen if you're fasting before consumption. So eating regularly is important to prevent high serum potassium levels. Certainly we know about medications, and I think most of you are probably familiar with the effects of like ACE and ARBs, that those increase potassium levels. But did you know that diuretics can contribute as much as 4.8 grams of potassium salt for one medication? And something as simple as an NSAID like ibuprofen that you might take for a headache increases your serum potassium level. Certainly, potassium salts and additives are much more bioavailable. 5 to 6 grams of a salt substitute can supply 1,000 to 1,200 milligrams of extra potassium to the diet. One study that was done looking at natural foods without potassium additives and those with potassium additives found that in a food that 100 grams of has 387 milligrams of potassium. If they chose products that had potassium additives to them, these numbers went up to 692 to 930 milligrams potassium per 100 grams of food. That's 2 to 3 times as much potassium in the same food. We also know, because of the cell integrity of plant-based foods, that potassium is only 50 to 60% absorbed, where with these processed foods, it's 90 to 100% absorbed. These are this is the diagram, sort of the how-to that comes from the clinical practice recommendations for potassium that just came out in the last year from the Pediatric Renal Nutrition Task Force. And I wanted to highlight a couple things here. You'll notice we start by assessing the diet. Certainly we want to look for foods that may contain potassium additives, sources of potassium in supplements and formulas. But then we want to, as our very next thing, before we even change the diet, consider non-dietary causes, like I just talked about. And we only adjust the dietary potassium intake if we have elevated levels. There's no need to do it preemptively. And then if we look over here, one of our main education points is looking for food additives and checking labels for potassium. So just to give you a different perspective, kind of a new way of looking at things, potassium to fiber ratio. If we know that fiber is beneficial in the diet, that hopefully these last few slides convinced you that fiber really is important for our patients, let's get the most bang for our buck. Let's give our patients the most fiber that we can for the least amount of potassium. Now, this isn't perfect. Pumpkin is very high in potassium. Pineapple, not as much, but the potassium to fiber ratio would maybe make it look so. But certainly, there's a lot of foods at the top of these lists that are great foods that if we're concerned about dietary potassium intake, if we want to be cautious, if we don't want to promote super high potassium foods, these are foods that we can still be encouraging to our patients to get them to eat more plant-based foods. So it's time for a quiz now. Which of the following do you think has the most potassium? And these are typical serving sizes, what I've listed here, what a person would probably eat if they ate these foods, but you can see the gram amounts. Okay, well, you guys were right, or at least the majority of you were right. It is the T-bone steak. All of these foods are considered high potassium foods, and all except the T-bone steak would probably be on a handout of foods to limit. The banana has, and I analyzed these all using the USDA database. I wanted to go to a non-biased source. The banana has 375 milligrams. The steak, 1,020 milligrams of potassium. The raisins, 340, and the sweet potato, 347. The steak had 3 times as much, nearly 3 times as much as the other 3 foods listed, which really leads me to this next slide. I wanted to highlight what I thought was an absolutely fantastic research study. This is a study that came out in JRIN in the last year, and I loved it so much that I just put the abstract up and highlighted some things that I really wanted to point out. What these resource materials that come from common sources that we're giving our patients, this group analyzed some of these common general CKD resources on potassium. And what they found is that all of the resources encourage restriction of fruits and vegetables. Over half encourage the restriction of whole grains. Over half encourage the restriction of plant-based proteins. But only 28% mention the restriction of potassium additives in ultra-processed foods. So what we find is that even though meats typically have more than 200 milligrams of potassium per serving, and in many cases that is considered a high potassium food. It kind of depends on what metric you're looking at, and different handouts are designed differently. But I think for so many years we've been so worried about albumin and getting protein in, and now we're kind of realizing, oh, albumin's more of a marker of inflammation, and realizing that our patients may not need as much protein, especially our patients, our young pediatric patients may not need as much protein as we think, and that there's other ways of getting that protein in. But our handouts haven't caught up. Our handouts are still saying to limit fruits and vegetables, and not worrying about protein, even though meats are really a very high source of potassium as well. So moving on, let's talk about this a little bit. And of note, we know that Canada is second only to the United States for consumption of ultra-processed foods. North America, we like our processed foods. So this article then goes on to say that considering glycemic management, management of acidosis, bowel routine, and medication assessment may be something that we need to be thinking about a little bit more instead of plant-based foods as to limit for potassium. So we know that there's no direct cause and effect relationship between high potassium foods and serum levels. We know that potassium additives increase potassium content by at least 20% on average, and that they're 90 or more percent absorbed. And that the alkali effect of plant foods causes shifts into those intracellular spaces. Thus, we don't absorb as much potassium from those plant-based foods. And I would argue that the body is more efficient in the absorption of nutrients from those plant-based foods, and the other benefits of the plant-based foods may be where we're seeing some of the major benefits with, quote, high potassium foods. So let's move on now to implementation, what I'm really excited to talk to you about. So some ideas. Getting started. Again, like I said, I've got a carnivore for a husband. Just introducing the concept of, hey, let's maybe not eat meat at every meal has been a challenge in my own family and many of the families that I've worked with. Certainly, I think cooking classes are ideal, but even videos, so taking around a tablet or an iPad during your rounds during hemodialysis and maybe showing each of your patients, your adolescents, families, hey, this is how you cook beans, or this is how you make a dish with eggplant, something very simple that we can be teaching our families through video, how to actually cook fruits and vegetables. I mentioned my student example before. Just ask yourself, we're so entree focused in the US and North America, what fruit and vegetable can I add to this? It's sometimes about adding instead of taking away. Promoting that my plate diagram that I think is a good visual for patients, that half the plate should be fruits and vegetables. Stocking your kitchen. I know myself, and if I stock my pantry with chips, I'm going to eat chips. What I've started doing is having some containers right on top of my kitchen counter with dates and nuts that I enjoy as snacks. So they're quick and handy and easy to grab. Making things easy is important. The Meatless Monday concept. Even just one day a week without meat has not only a health impact, but we know that it may improve our environment as well. Adding a fruit and veggie. Let's say you know you're not going to have time to grab lunch and you have to grab a burger through the drive-through. You can maybe grab a baggie of baby carrots and an apple to take with you that morning, so that you don't have to get the fries, the processed food on your way through. Picking just one meal a week to experiment with. I mentioned to you, I've had some flops with my own attempts at this, but one meal for the whole week isn't that big of a deal as if you had planned a whole week of plant-based foods that are new recipes. And then a lot of these ideas come straight from some vegetarian or more plant-based websites like Forks Over Knives. And one of their suggestions for adults was, on a typical 2,000 calorie diet, try making half of the foods plant-based. So this would be less for younger kids. When we consider protein, we do need to encourage protein-rich foods such as beans, lentils, and nuts. So we are getting enough protein, and especially with starches, those are going to work. If we're overwhelmed, eat more of the plant-based foods you do like. If you like nuts, if you like beans, eat more of those, and maybe don't worry if you've never tried some random vegetable that you've never had before. Start with what you know. Eliminate animal proteins you don't like, or don't care for as much. If they're not your favorites, those can be the first to go. There's a lot of simple 4 or 5 ingredient recipes out there. Making big batches. So if you make, let's say, a vegetarian chili, save the leftovers for a lunch or two that week, and maybe put the rest in individual freezer containers, so that in a month from now, on a rainy day when you don't want to cook, you have it handy. Now, this next one doesn't work well for our lower socioeconomic families, but those meal boxes like HelloFresh, Blue Apron, all of those are becoming very trendy. A lot of those have vegetarian options. Encourage your families to try those if they're using those services anyway. These are just a few meal ideas that I came up with sort of off the top of my head. Um, Certainly, I'm sure that you all could come up with more. I really like beans, so probably a lot of these, a greater proportion of these are bean based because I find that they're a great protein source. But we've got ideas for breakfast on here. A lot of ethnic foods, ramen. We think of those awful high sodium packets that our patients like to eat, but homemade ramen actually can be pretty healthy, especially if we load it up with veggies. Just about anything you can make into a sandwich with any kind of nut butter or hummus on it. Um, there's all sorts of ideas out here. And if there's not enough ideas on this, the Meatless Mondays has a lot of recipes, not to promote a particular brand, but the S&W Bean website has a ton of recipes. You don't have to use their brand of beans. Just get their recipes that are available off their website. Forks Over Knives has a lot of recipes as well. So again, I'm sure you guys could come up with a million ideas on your own, but these are just some that I came up with. Choosing, if you want to build a meal and teach our families how to build a meal, start with a base. Certainly, a potato prepared in a low potassium way is an option if we're wanting to avoid high potassium foods. A lot of these are better if we choose whole grain or like brown rice, but if we're slowly working families into this doesn't have to be a deal breaker. Things like corn or tortilla chips, not maybe our number one healthiest food ever, but they do tend to be lower in sodium than some other chip options, and they can make great taco salads. We want to include a protein source then just to make sure we're getting this, and a lot of these with our base are complementary proteins. And then adding fruits and vegetables on the side or turning some of these into sauces to complement the bases that we've chosen, as well as teaching families to use spices and herbs, oils, vinegars. I often tell families that need to add calories to their kids' diet to add a splash of olive oil to noodles, to veggies, because not only does it add calories, but it adds healthy fats and a lot of flavor. So these are just a few combos. If we're looking at meals, I've got a breakfast option on here, flaked corn cereal with soy milk and berries. And again, it depends how plant-based you want to go. It doesn't have to be soy milk. It can be regular milk, but we're just choosing more plant-based options. Noodles with mushrooms, light tomato sauce, or even like a pepper sauce. Lots of options to build your own meal. Another way of looking at things that I wanted to point out to you, and again, this doesn't work for every patient. This is really something to consider on an individual patient's, is considering calorie to potassium ratio. If you're worried about too much potassium in the diet, again, we want to get the most bang for our buck. So if we need to teach our families to eat enough food to fill up without getting too much potassium, we can look at calorie to potassium ratio. And again, I just analyzed this myself looking at the USDA food database. So you could certainly, I just did a smattering of different types of foods here for comparison purposes, but certainly you could dig into this a lot more on your own. I try to look at different grains, different nuts or seeds, fruit, different vegetables. For example, both almonds and walnuts are great foods, but if you have a child that really needs the calories, I would maybe promote walnuts a little bit more because they've got a higher calorie to protein potassium ratio. If you have a patient that's overweight, this might not be as big of a deal because we might not want to be packing calories in. So one thing that some of these different articles and even the clinical practice recommendations from the task force talk about is altering food prep of high potassium foods. Now, to me, this is kind of a sticky subject because I think it can overwhelm our families as if we're asking them to make things more complicated in their cooking. So just to kind of look at some options, If we are truly trying to limit high potassium foods in the diet, we can lower potassium content of many vegetables by boiling them. And actually, the best option is boil, rinse, and boil again. This may make some previously unallowed foods, perhaps some favorites like potatoes, I know is a big favorite of many kids, possibly available. Now, the cons, it's time consuming and it's a bit messy because the best potassium leaching is done by shredding food. And again, this boil, rinse, boil method, we may reduce other nutrients, which I think is less than desirable, and we may make foods less palatable. So it's up to you, but it is a technique that's available. So again, I like to go for low-hanging fruit. We don't, as pediatric renal dietitians, we don't have to reinvent the wheel. There's a lot of great general resources out there that we can still use with our patients. The Academy's Vegetarian Nutrition Practice Group has a bunch of handouts on their website that are free, even if you're not a DPG member. I pulled the one for school-age children, but there's also one for infants and toddlers and teens. There's ones for specific nutrients like zinc or B12, and there's general resources on how to gradually incorporate more plant-based foods, as well as a joint effort between the renal DPG and the vegetarian DPG, because this is such a hot topic in CKD, to make one specifically for CKG. I want to touch on cost and food economy. I know personally in my adult life, I've gone through periods of time where I've really had to watch every penny on what I buy. And I think especially with food costs going up, we especially have to be aware of this. Again, these are general resources, but ones that I think are great low-hanging fruit that we can quickly print for our families. For example, this one from the USDA that focuses on foods that are available on like SNAP and for people that are on budgets, foods under $1. Certainly, this is one from Iowa Extension that has a cookbook for eating healthy on a budget. And then these two down below that talk about making the most of produce. And this one I really love because now I go to the grocery store once a week. I don't like going more than once a week. And I know that I probably want to eat my strawberries first, where something like apples are going to last later in the week. Not all of our families know this. I think even just printing something simple like this, which foods spoil the fastest, so our families feel like they can be getting the most for their money. One thing, and again, I realize this isn't as applicable if you live in, let's say, Alaska, parts of Canada, or even other parts of the world. But I think this concept is what we really want to be promoting to our patients and families. These are numbers that I just pulled from a Midwest grocery store where I live. But again, I think the concepts are similar. Now, if you looked at this, from just, let's say we looked at red seedless grapes compared to mac and cheese, the mac and cheese is going to seem like a bigger deal or better deal. But if we look at this as a whole, you'll find that on average, nutrient dense foods do not have to be more expensive. And I think people have this mindset that healthy food has to be expensive. Now we need to teach families to buy foods in season, not to buy specialty or organic foods if they need to save money, and that store brands are a good deal. These foods that I have listed down here are store brands. But if you look overall, the average price per ounce, and keep in mind the weight of food promotes satiety, is much less at 13 cents an ounce compared to these processed and convenience foods at 27 cents per ounce. Speaking of seasonal food, I've included a couple resources. This one is done by the extension groups in Nebraska, Iowa, Missouri, and Kansas, which I realize is the Midwest, but I think it could still be applicable to other states. Just out of curiosity, I wanted to see if there was one for other states, and there is, but it wasn't quite as detailed as the seasonal and simple, which has not only information about the food and when it's available, but it links to recipes that uses those foods. So I think either resource could be great if you're trying to teach your families how to buy seasonal food. So let's move on to the case study, our interactive part of today. This is a past patient of mine who was a 9-year-old on hemodialysis with neurogenic bladder. She's on a traditional renal diet. The family actually was in a homeless shelter for a while, but they moved into low-income housing. She has 2 younger siblings, so this mom has her hands full. Her weight's a little bit low. You can see that potassium is a little bit scary. All of her other labs are pretty stable. So after seeing this patient, tell me what else you want to know. And Michelle can read out some of the comments to me.
Typical diet, food frequency,
Mm-hmm.
her
Great
usual
one.
intake,
Mm-hmm.
what medications is she on,
Great question.
potassium intake and sources.
Mm-hmm.
Oh, everyone's hitting it with the medications.
Mm-hmm.
Um, bowel patterns. Did not get to see the labs. Is she acidotic?
Oh, her bicarb's 22.
Yep,
Kind of
bicarb 22.
borderline. Kind of
Okay.
borderline.
Food preferences.
Okay.
I think that's
Just
all we got
just
for
in the
now.
interest of time, I'm gonna move on. There's lots, there were, you guys all had great answers, and I think that we could have discussed lots of things. I just listed some here that I thought of. Medications, like you all mentioned. Are they increasing potassium? How often does she get hemodialysis? What potassium bath she's on? What's her growth history? Foods available? What is she eating? You mentioned food frequency. I'd like to know about, do they even have a refrigerator or stove? Stooling habits was a big one for me. Is she constipated? As well as some psychosocial issues. So we've talked about plant-based diets, but I want to know what general recommendations you all would make.
Um, more calories to stabilize
Mm-hmm.
weight.
Mm-hmm.
Ensure medications are reviewed. Optimize dialysis treatments and review diet. Yes, yes. Um, general recommendation, cut back on processed potassium sources. Check
Great.
possible excessive amounts of vegetables and fruits.
Okay. Okay. In the interest of time, I'm going to move on. Um, okay. So some things I felt we should evaluate: stooling, maybe address constipation, which she was, which needed to be addressed. Thorough diet eval. Many of you mentioned, does she have potassium additives? Many of you mentioned dialysis. Could we? And that is one thing we did, was we started her on a 1K for the first hour for potassium bath in her dialysis. Um, Assessing her diet intake, figuring out ways to increase calories because her weight is low. Of note, her weight had been trending down. Certainly knowing what food she likes. This one was a big one for me, evaluating physical activity and muscle mass. What I ultimately found with this patient was she was incredibly malnourished. Her weight was trending down. I believe she was in catabolism because when we got her eating more, her potassium improved. I think it was all muscle release from her breaking down her muscle stores. So I felt like the team was yelling at me to limit high potassium foods in her diet. I'm like, she's not eating anything, let alone high potassium foods. So that was actually the real problem. So this is a patient that I had back in the day before I think we knew all this about plant-based diets, but if I had to do over again, I think I would have wanted to introduce more of a plant-based diet with her. So I would love your ideas on how we could have incorporated a more plant-based diet for this family that was limited on time and socioeconomic resources.
Okay, frozen fruits and veggies. Fruits
Great.
and veggies which are in season. Canned beans, lentils, frozen produce, tofu, nut butters, more nut butters, oils,
Mhm.
seeds. Find out what their staple foods are and come up with realistic alternatives.
Oh, I love that idea. Let's see what they like.
Canned low sodium veggies and syrup fruits. Teach meal prep with low budget items so meals are prepped ahead of time. Cook
Great.
beans from dried, cheaper than canned, and buy things on sale.
Great. So many of you guys mentioned the exact same things I was thinking of. Noodles, nut butters, canned beans or dry beans, teaching the family how to use those, fruit canned in juice, oils, work with social programs to provide these foods. So one thing I came up with is a sample menu. Now, this child's needs was actually just over 1,300 calories. And you'll notice I made an 1,800, almost 1,900 calorie menu. And that was to hopefully show that even for a larger kid, this is possible. This could promote weight gain in this child that was malnourished. Or if they don't have access to or like all these foods, she doesn't have to eat all of this because I've sort of purposely created a buffer with more than enough calories and protein, and you'll notice that it's plenty low in potassium. I chose to do plant-based, mostly vegetarian, but not vegan, but certainly if something like rice milk isn't available, regular milk is fine. I chose to do honey over jelly just because I think it's slightly healthier. But you'll notice simple things like sandwiches, a peanut butter or another kind of nut butter sandwich, or you could do a pita with hummus in the middle. Those foods don't have to be expensive. Noodles are fairly inexpensive. Pesto you can get in a can. So lots of ideas that I think are pretty simple to do. Frozen berries, if they're not in season, are realistic and doable. And again, we do have to see what our patients' preferences are. But hopefully that gives you some ideas. And just to wrap up today, my references follow. But I just want to thank you for your time. And I know we're right at time, but I'm happy to take any questions you have.
Thank you, Christina, for such an informative presentation. I have been looking forward to this one, and you did not disappoint.
Thank you, Michelle.
So, yes, if people could just enter your questions into the questions pane. I do have one question so far. It's from Lori, and her question is, do you feel it's necessary to transition over to a plant-based diet, or can you do it rather quickly?
It totally depends on the patient and their family. Some people are very, let's get this done, let's go to it. I know most of the patients I've worked with and most people I know kind of do better with a transition because it can be a little overwhelming. And one thing we do need to keep in mind is if we go from no fiber to lots of fiber, we could have GI upset. So that is one thing to think about. I don't know if any of you tuned into the obesity and metabolic syndrome webinar that I was part of about a week ago from the task force, but I presented a case of a patient who he was an obese patient. He chose to pursue a plant-based diet on his own from the research he did, and because he had a family member with cancer and he felt like that was best. Well, he embraced it whole hog. If you've got a patient like that, go for it. Be their biggest cheerleader. But most families, I would say, need more of the approach of let's do a meatless Monday. Let's try to include more fruits and vegetables.
Great, thank you. Okay, I've got a question from another Christina. What would be a starting point in introducing veggies, fruits in a patient who is extremely picky, high protein eater?
Oh, that's a great question. I've dealt with many of those. I think hiding veggies is really helpful. So I've got a picky eater of my own, and so we do a lot of things like soup that has really cut up fine vegetables. We don't make those peppers any more than just a quarter of an inch when we cut them up. So getting them used to foods that are more cut up. I always start with fruit. I find that fruit is more often enjoyed by young people, especially things like berries. And again, you could do frozen berries in smoothies. One of my favorite, I mentioned that my black bean soup is popular in my family. It's a pureed base. And for people who have texture issues, that can be really helpful. It's really just finding individual pickinesses, if that's even a word. But I find that each child kind of has their own texture issues and their own hangups. It's almost always texture over flavor. Um, and figuring out what their individual hangups are and trying to work around those.
How do you optimize iron intake in kids that are following a plant-based diet? So iron, Christina, what do we do about that?
Well, I think one thing you have to keep in mind with CKD patients is that they have abnormal iron indices anyway. So this is one that I'm a little less concerned about in some of my patients because by the time we hit about CKD stage 3, a lot of our patients, just because their kidneys aren't utilizing epogen appropriately or erythropoietin, I guess would be the better term to use, they have to be given that exogenously, and our nephrologists really kind of micromanage issues like erythropoietin and iron. So it's actually one that I know is not going to be optimal for many of our patients and has to be adjusted anyway. So in many ways, that makes my job a little bit easier. But if we're looking strictly from a diet standpoint, we do know that things like greens and beans have iron in them, and certainly encouraging vitamin C rich foods consumed at the same time. So there are ways around this, but honestly, on my list of priorities, this is a little bit lower, knowing what we do about CKD.
Okay, I think we have one last question. This is from Lucy. Do you now follow any quotes, restrictions in the amount and sorts of fruits and veggies? And banana is being used as an example.
Great question. So I think this really depends on individual practice. Honestly, even 15 years ago, before we knew a lot of this, I was pretty liberal on potassium. When I would meet other people at conferences and talk about diet restrictions, my patients were always on way more liberal potassium restrictions than most of the other dietitians I talked to. Um, the reason I think we were pretty successful at my facility with this is my docs were on top of it when it came to bowel regimen. And issues like acidosis. You know, in that patient, in that last case study, you'll notice her bicarb was 22. I made it kind of borderline on purpose because I actually really like my patients to be more like 24, 25. I don't have any evidence for that per se specifically, but I just found they had better outcomes, better potassium levels, especially my CKD kids who are on ACE inhibitors, if they had a bit higher serum bicarbonate. And I think we enjoyed letting our kids be a little more liberalized because and I can't take credit. It was docs and nurses at my facility were so on top of this. I would say that just because we don't want an acute influx of a ton of potassium at once, I'm certainly not going to be promoting that we eat sweet potatoes all day. My rule of thumb was no more than 2 high potassium foods and make sure they're at different meals. So I'm probably more liberal on this than many dietitians, and I think you have to consider the practice of your whole team and what they're comfortable with.
Great. Christina, I'm going to sneak in one more. It's a good question and it's quick. So if
Okay.
you don't mind, this
No.
is from Jackie. How often are you assessing total potassium intake in one's diet, like actually adding up the milligrams?
Oh gosh. To be honest, not very often. I'm and to be fair, I'm more of an eyeball type of dietitian. Um, when you've been doing this a while, you kind of know what foods to look for. You know what food. Oh, I bet you're eating this that has a potassium additive or whatnot. So I would say I don't do that very often. I would say once a year, try to get in a full scale dietary evaluation. I would love thoughts from other dietitians out there that are listening, just because we're busy as dietitians. We have a lot of patients to care for, and it's hard to microanalyze diets that closely. So I would say annually is maybe a good goal to shoot for, but and maybe on a surface level quarterly. But I would love thoughts from other dietitians.
Lucy, I do it more often in formula-fed kids.
Makes sense. Yeah, well, yeah, when you have a whole spreadsheet with what their formula contains, yeah, it's a lot easier.
And
For
she goes
oral,
on, yeah, not so much with kids who are eating
yeah,
regularly.
yeah.
Okay. Well, I think we are past time,
Mhm.
so I am going to close the webinar down. Christina, again, I just really wanted to thank you for this. I thought this was really a fascinating topic. I'd also love to thank our audience for your participation. And then just on behalf of VIA, VitaFlow in association with you, we hope that you found this information valuable to your practice and that you have a great rest of your day. Thank
Thanks,
you.
everyone.